computer tool. Hello. Yeah, good
Yes,
morning, good afternoon, everyone. This is James Carrier from WHO here in Geneva, and inviting everyone who is on the webinar. We are starting now, and just to give maybe a bit of background, is a follow-up on the stakeholder meeting on DMPA and HIV acquisition risk that was held in Johannesburg, I think way back in April 2017. And as you recall, we had various stakeholders in this meeting, and importantly, I think we had the Ministry of Health colleagues and WHO representation from the 10 countries where this question is of particular concern. And at the meeting, it was agreed to have follow-up discussions that would coincide with the release of the Global Handbook for FP providers that has proposed messaging on this issue. So we are not quite there, and I think we'll hear more about from Marilyn what is contained there and what are the plans regarding the Global Handbook. But since we are fairly close, we thought this would be a good time to have the webinar. So for today, we have three presentations. The first one is from Petrus Stein, a research scientist here in WHO, and he will basically go over some of the discussions we had at the meeting so that to put context to the follow-up presentations. The next one will be by Marilyn Garfield, a scientist here in WHO, who will give an update on the Global Handbook. And then we have Nancy Kidula, who is a senior reproductive health specialist and a medical officer in WHO Afro, and is responsible for the East and Southern African region. And will give feedback on the country activities. I think the best way to proceed is that we'll have all the three presentations, and then we have about 20 minutes or 25 minutes, so we have a quite adequate amount of time at the end where people can also give their updates, and also if there are any questions or interventions, this can be given at that time. And on the webinar, there's a function of raising your hand. So at the end, if you can raise your hand, then Ados and Stephen, who are managing the webinar, can be able to unmute your microphone and you can give your intervention. So I hand over to Petrus Stein for his presentation.
Thank you very much, James. Next slide, please. I'm really just going to go through the objectives and themes of the meetings, and then the objectives of this meeting, of this webinar that James already touched on. Next slide, please. So, if you recall, the meeting took place in April 2017 in Johannesburg, and it was basically two meetings. First one was a technical consultation to review the progress in the field since the previous meeting and agree on strategies to address barriers. It was to review the new WHO statement and its implications for research, program and policy, and to explore strategies to address the gaps identified in the research, programs and policy. So we have sent out the report on that meeting quite a time ago. The second meeting, the objectives of the dissemination meeting, was to plan for country implementation of WHO guidance on hormonal contraception and HIV. Next slide, please. So just more into the themes of the two meetings. First of all, the technical consultation. For people who remember, there was a December 2015 stakeholders meeting held in Geneva, and we discussed developments since the meeting and identified areas for improvement in research methodology and measurement to strengthen future research. Then programmatic recommendations to ensure high quality provision of HIV and family planning care. As I mentioned, the new WHO guidance and its implications. And then also we had a session on anticipating possible scenarios for the ECHO study results and appropriate action for each scenario. For the second meeting, there was sharing of the statement and rollout plans by WHO and plans to support implementation by others. Key messages, opportunities, and challenges to implement the statement, including counseling and other implementation tools, were discussed. And then also we had a session on key planned actions by countries. Next slide, please. So the objectives of this webinar is really an update on the Global Handbook for Family Planning regarding HIV and hormonal contraceptives, which Marilyn will just speak about now, on messages, related parts in the book, and the risk assessment. This book will be launched or available on the 15th of February. And then Nancy will address the questions on the action plans of selected countries. Thank you very much. Next slide, please.
Thank you very much, Petrus. And now I'll hand over to Marilyn Garfield. Dr. Marilyn Garfield, as I said, is a scientist working with us here in WHO. And I think it's very good that she is presenting on this issue because she has been the backbone of the department in development of family planning guidelines for quite a number of years. So I think she's very familiar with the various recommendations regarding this issue and how they have even developed over time. So Marilyn, over to you.
Thank you very much, James, and Happy New Year to all of you. And we're really pleased to be able to talk to you about the upcoming release, as Petrus just mentioned, of the Global Handbook for Family Planning Providers. As you probably all are well aware, it's taken quite a while. It's been a long gestation, but we're really proud of all the contributions everybody has made to make this a really useful, practical document. Can we go to the next slide, please? And in particular, I want to thank all of you on the call because I know the discussions that were held in Johannesburg and all of your suggestions really have helped shape what will now be in this handbook. So just to start with, I'm sure all of you are very well familiar, but the Family Planning Handbook is a practical guide for providers of family planning. Just want to highlight that the slide here shows that the 2017 update, we actually at the very last minute, that's actually going to say 2018. But the new handbook will have, for all of you that are familiar with the current handbook, will have the same format, presentation, just be much richer in additional content. So from our perspective, this handbook consolidates the recommendations that are issued in the medical eligibility criteria for contraceptive use, so meaning the 5th edition that was launched in early June of 2015. It also includes all of the recommendations, including the new and updated recommendations that are issued in the 3rd edition of the Selected Practice Recommendations for Contraceptive Use Guidance. And then particularly for this discussion, we made every effort, and also thanks to all of your contributions, to ensure that the content in the 2017 guidance around hormonal contraception for women at high risk of HIV was integrated into the 2018 Global Handbook. Can we have the next slide, please? So just wanted, before we really dive into the content specific to hormonal contraception and HIV, I want to alert you that indeed this new edition will include the recommendations issued in the documents that were presented on the other slide and the preceding slide, but also want to just put in a little pitch that this new edition is going to contain additional expanded coverage on a variety of issues that confront providers and programs. And we hope this will really make this document, this resource, even more valuable. So, there will be, and we've really made every effort to ensure that WHO recommendations regarding task sharing, violence, etc., are part of this resource. And then we've also ensured now that there's more information coming from WHO. We've also added more information on infertility and prenatal and antenatal care and provision of implants as far as insertion. So just to say, this will be not only for the particular issue of hormonal contraception and HIV, but we believe this will be an invaluable resource for all of us. Next slide, please. So really the topic at hand is what are we saying in this handbook regarding progestin-only injectables? And so through this effort that's been several years in the making, we've updated the chapter on progestin-only injectables. And this chapter, for those of you familiar, includes general information that the provider should know about the mechanisms of action, the method itself, also key information from the MEC and SPR on how to deliver injectables. So, who the eligibility criteria, and then the instructions on how to initiate, continue use. We've even now included information on self-injection, and then a lot of really useful counseling suggestions and tips about how to engage partners, how to manage problems, and then again thinking along the lines of what providers need to know. We've also got frequently asked questions, and then evidence-based responses to those. And then also, as we talked about in Johannesburg, we, and particularly given the complexities around counseling for women at high risk of HIV for this particular method, we include some suggestions for counseling. So next slide, please. So thanks to your inputs, we now have in the handbook, and it's actually towards the back as an annex, we have some counseling tips that providers can apply when they're discussing progestin-only injectables with women who are at high, or women and girls, clients who are at high risk of HIV. And we've basically summarized this in two parts. First, kind of what are the key facts that need to be conveyed to clients who are considering use of injectables. And then we talk about, we have some key tips on how to discuss these facts and help the woman come to a decision. So we've got, in our counseling tips, we've got 5 key facts that we believe providers should convey to their clients. First, that some research has found that women who use progestin-only injectables and are exposed to HIV are slightly more likely than other women to get an HIV infection. They also need to convey that the meaning of these findings is not clear. We don't know whether or not this method causes this higher risk. They also importantly need to say that a client can protect herself from HIV. Also, that she can still choose this method, but that she should think about the information that is being shared with her. And then lastly, there are other long-acting and effective methods that are available, and if she would like, that a discussion about those methods can be undertaken as well. So kind of 5 key facts, and this really took on board the suggestions that you had, that you conveyed in Johannesburg, and then also the technical information in the 2017 guidance statement. Next slide, please. Additionally, once these 5 key facts are shared and discussed, we offer some suggestions of how a provider might help a woman consider whether or not she actually wants to use injectables. So firstly, the provider can talk to her about, is she doing anything to protect herself from HIV infection? So the provider can discuss how she protects herself from HIV. And then also, if she's not protecting herself, could she start protecting herself now? So the provider could then use this opportunity to discuss the various HIV protection choices that are available. Secondly, providers can ask her, does she prefer a progestin-only injectable much more than any other method? And in fact, if she does, the provider can reassure her that she can choose a progestin-only injectable if she does prefer it. The provider can also discuss whether or not she'd like to discuss and think about other methods too. And at this point, the provider can mention and discuss particularly, for example, other long-lasting, effective, and convenient methods. This would be an opportunity to talk about implants or intrauterine devices if the woman, the client, is interested. So this information, these tips, will be what is published in the 2018 Family Planning Handbook. Next slide, please. And then thanks to your input, we also believe we have 13 different frequently asked questions for providers to refer to if they need to in the injectable chapter. And we've added, for this edition, a question asking, can women at high risk of HIV use progestin-only injectables? And we respond with an answer of yes, women at high risk of HIV infection can use any contraceptive methods, including progestin-only injectables, but they shouldn't use spermicide or diaphragm with spermicide. And we also include some additional information that, again, supports this response. Next slide. So as Petrus and James have mentioned, we're really pleased to alert you in advance that the 2018 Global Handbook will soon be available. It's going to be, shall we say, soft launched in New Delhi during an Implementing Best Practices regional meeting that's taking place the 13th through 15th of February. But on the 15th, time is set aside to deliver the launching. And from this date onwards, the electronic copies of the handbook will be available on WHO's website with a link, really, to the address that I show here on the slide. So at this www.fphandbook.org, that will be where you and your partners, colleagues, can download and refer to the 2018 handbook. We are of the understanding that this is a joint publication between WHO and Johns Hopkins University, and Johns Hopkins University is in the process of printing copies, hard copies of the handbook. At the moment, I am not aware of the number of copies, but they are very well aware that it's very nice to have electronic copies available, but they also are very aware that hard copies are of great importance in the field. So printed copies will be soon available, but at least on the 15th of February, it'll only be electronic at the time. We've provided a link to where you can order copies of the handbook. And also I want to let you know that the Johns Hopkins does plan to undertake, at least for the time being, they have committed to undertake Spanish and French translations of the handbook. And they are going to start on that work as soon as possible. And we at WHO have sent all the translated materials we do have of our guidelines to help guide that process. They may be able to undertake additional translations, but that it may be a bit of a resource issue. But for Francophone countries and Hispanophone countries, a translation of the 2018 edition will be made available as soon as possible. So I think at that moment, I think that's, for the time being, that's the end of my slides. So over to others on the call.
Go ahead, Nancy. James is experiencing some audio problems.
Okay.
Thank you.
Okay, good afternoon from Harare. This is Nancy, a focal person for reproductive and women's health in Eastern and Southern Africa. Next slide, please. Next slide. Next slide, okay. For us in Eastern and Southern Africa, this particular statement on the use of hormonal contraceptives in women at high risk of HIV was really important, as was the meeting in Johannesburg, because as many of you know, this is a region that has high HIV prevalence, and it also has high utilization of progesterone-only injectables and DMPA in particular. In this sub-region, we also find that the provision and utilization of other long-acting reversible contraceptive methods such as intrauterine devices and implants has been low for many countries. So there's a lot of dependency on the DMPA as a preferred method of contraception in the sub-region. Therefore, the meeting in Johannesburg was really important for us because we needed to really be clear on whether we need to change any policies, change any programming in view of the recommendation or the statement that was released by WHO. In that meeting, we had 12 out of the 20 countries in the Eastern and Southern Africa sub-region, and you can see them there. And they made detailed action plans after the meeting. And in this presentation, I will only concentrate on the ones directly related to the statement. We also know that in this sub-region, we have a lot of concerns about the risks of contraception, and these are among the most common reasons for non-use of different contraceptive methods. Next slide, please. So I will give a synopsis of what the different countries did and their reactions after the meeting and where they are at now. just to say that almost all the countries that were at the meeting were either in the process of reviewing their family planning guidelines and tools or were planning to do so. And subsequently, they have done so, except I think only one country. So if we start with Zimbabwe, like all the other countries, after the meeting, they shared the statement and the proceedings with their country team, but they did note that the results of the ECHO trial were not yet finalized, and they needed to consult further with other stakeholders, specifically the academia. The position of the country as of now is that DMPA should still be used regardless of a woman's HIV status, as the recategorization from 1 asterisk to 2 did not limit its use. And so the provision of DMPA is still ongoing. For Zambia, they did the same, and thereafter they adapted the WHO medical eligibility criteria 2015 wheel to the national context and ensured that the recategorization was reflected in that tool. They are in process of developing a national communication strategy that will incorporate the new guidance as has been shared by Marilyn. In Botswana, we had the family planning guidelines and MEC-WIL revised last year. They have disseminated the statement on hormonal contraceptives and HIV in different forums. And right there we see an excerpt of what is in the draft guidelines that really corresponds to what Marilyn has shared that will be reflected in the handbook. Next slide, please. For Uganda, in Uganda, as we know, this really statement was not really new. We had been hearing things about possible relationship between hormonal contraceptives and HIV risk. So many of the stakeholders were already aware of this statement. However, the meeting still was held to further disseminate the statement, and printed copies were distributed and are being used in trainings and other meetings, like when they were being oriented on Cyanopress, they included the DMPA subcutaneous, they included the statement. Cyanopress, we all know, is the DMPA in subcutaneous formulation. Uganda is also in process of finalizing a communication strategy where they are going to agree on really how they are going to communicate this message to the stakeholders so that they don't compromise clients' health, counseling, and also do not compromise the family planning program. In addition, they are actually intensifying capacity building for other methods, especially the long-acting reversible methods, in anticipation of any results from the ECHO or other studies. If they confirm the relationship, then the country is prepared and has the systems in place to deliver alternative family planning methods. They are also giving more messages on HIV prevention and disseminating them in collaboration with the AAHIV team. Next slide, please. For Tanzania, like the other countries, after the 2016 meeting, they presented the statement to the technical working group, which endorsed the recommendations and tasked a small task force to prepare communication materials to respond to the statement, which can be user-friendly and that can be easily disseminated and understood in the country. Let's remember that Tanzania, the normal communication language in most setups is Swahili, and they had to think of how to communicate this message, because as we all know, when we say conclusive, you have to think what is the equivalent word in the commonly used language that will communicate the same message as what was in the original statement. Tanzania has also revised the family planning guidelines and training packages in line with the new WHO recommendations that we had, that is the MEC, the SPR, and the hormonal contraceptive HIV statement. They are taken cognizant of the recategorization, and they are having intensive capacity building for expanded method mix in collaboration with HIV counterparts, also to ensure that the messaging in the HIV service areas is consistent with what is in the statement and what is recommended. Next slide, please. For Namibia, they also disseminated and shared the statement. Namibia has also revised their national family planning guidelines. They are in draft now, and they adapted the medical eligibility criteria wheel. They did capture the recategorization in the wheel. However, it was interesting that for Namibia, they felt that if the results of the evidence is still not conclusive, they did not feel that they can include it in a guideline that is going to last 5 years, because they wouldn't have resources to keep reviewing the guideline as and when they want. So they felt that that information would be included during their trainings, especially when they are training on counseling for the different methods, but in the guidelines, they would not include that particular statement as is reflected in the handbook, because they want to wait for the results of ECHO and other trials before making any changes in their policy and guidance document. Next slide, please. So in conclusion, we can say that in the ESA countries that attended the 2016 meeting, apart from all the other issues that they planned to do, which were many, and they have done quite a lot of work in response to their action plan, they disseminated the WHO statement widely. And this statement was not disseminated alone. They were disseminating together with them medical eligibility criteria, selected practice recommendation, human rights in contraception, PPFP, and all other normative guidance that has been released by WHO to inform planning and programming. There are countries that felt that the communication focusing on DMPA and HIV was premature, especially when the clarification had stated that the evidence was not conclusive and that the results of the ECHO and other trials are still awaited. However, most countries in the sub-region found the information to be very useful, but felt that it really didn't make much difference to their service delivery, because they routinely still cancel for dual contraception in women at risk and living with HIV, and the categorization being 2 means that generally can still use. So they felt that the only thing they really need to do is to strengthen the counseling when providing DMPA, or when a health worker is a client is seeking to use that method. We have also noted that many countries have accelerated capacity building efforts to enhance the method mix and the choice, especially for the long-acting reversible contraception, and they are including key messages in their communication strategy. I think I will end there. Next slide. I think that's all I have, but that is what has been happening in the Eastern and Southern Africa sub-region. Thank you.
Thank you very much, Nancy, for that very good presentation. And I think also congratulations to the people from the various countries for the follow-up actions, which have been quite significant. I think now we are open. We have still about 24 minutes on which we can have a discussion. So please, if you'd like to make any intervention, you can use the raise the hand function. I do not see any hands raised. So as we wait for people to ask questions, I would like to call upon Petrus, who had some additional information he wanted to give on the meeting.
Thank you, James. Just to mention that there was an article, a manuscript published on translating this research into practice by us, and we will send the link to them afterwards. And this is really looking at this meetings, the previous meetings, but then also looking at how WHO went about to disseminate this work, the guidelines. Thanks.
Okay, thank you very much. And Theopista, you have an intervention?
James, while we wait for Theopista, we did have some questions from Abdul Mumin Saad, specifically for Nancy. One of the questions that he asked in the chat box, which you should see in the chat box there, the first question, Nancy, is, are women being counseled on the potential risk of HIV acquisition and HIV preventative measures? If yes, can you please name the countries where counseling is being implemented and share experiences from a few of these countries? Nancy, do you have any comment on that first question?
Okay, thank you for the question. Right now, we don't have the specific response from countries on whether they are actually canceling on that increased potential increased risk of acquisition of HIV in women who use DMPA and that are at high risk. We do know, however, that all the countries that we have talked to are definitely canceling on HIV preventive measures and promoting dual contraception routinely as part of the family planning service provision. So we don't have the data. Maybe the countries that are on the call may be able to respond on that.
Thank you. It seems that we're having a few audio connection problems with James, but we do see that Andrew Gray has a question and has raised his hand. Andrew, we've opened the mic. Would you like to make your intervention at this time? Over to you.
Thank you very much. I noticed, Nancy, that you said there that you had a question mark after South Africa. It's true that South Africa is not planning to update its guidelines per se, the contraceptive national guidelines, which were only implemented in 2014. However, there is another document which is very important, and that's the Primary Healthcare Standard Treatment Guidelines and Essential Medicines List. And we have taken note of the WHO statement, and there will be a mention within the family planning chapter of the new PHC SDG, which is being developed at the moment, that makes reference to that. The National EML Committee meeting will happen next week on the 1st of February, and I will bring to the attention of the Secretariat that this new document will be coming out, the handbook from WHO, and it'll be really good in the cell phone app that is distributed in South Africa to make reference and put in a link so that people can open up the handbook if they want that series of questions. And we will also look at the content of those questions and see if they can be built into a table, for example, in the S.
Thank you very much, Andy. And we have another question from Lucy.
Lucy Mariba, you can go ahead. Your microphone is open. So James, we are experiencing a few issues with her connection, but there was another question for Nancy, and then followed by another question for Marilyn. The question for Nancy was, are any of the countries adopted or adapted the USAID HC3 Strategic Communication Framework for hormonal contraceptive methods and potential HIV-related risks? This was a question posed by Abdul Mumin Syed, who also provided a link, but this was a question specifically over to Nancy. Nancy, do you have any thoughts on that particular question?
As far as I know, most countries are currently still working on their communication strategies, and I think that will be very useful. I'm not sure of any country that has already adopted that particular one. So if we get that link in the webinar documents, then countries can benefit from adapting from it and including in their ongoing development of their national communication strategies. Over.
Stephen, go ahead and read the question for Marilyn.
Thank you. Marilyn, there was a question for you that came as well from Abdul Mumin. The question was, if women decide to discontinue use of DMPA due to the HIV counseling, how long should they be concerned about continued risk for HIV? Should we recommend they continue condom use for 3 to 6 months? Would switching to a different contraceptive impact the residual effect of DMPA? Marilyn, do you have any thoughts on that question? This was again from Abdul Mumin Syed.
Thank you. Thank you very much. Right when the function was unmuting, I may have missed a bit of the question, but if I understand correctly, the question is, if a woman if she's at high risk of HIV and she decides to not discontinue using DMPA and choose another method, are there what action should she take, and are there any lingering effects? Is that correct? From the prior use of DMPA, was that the question?
That is correct. The question is, if she chooses to discontinue use of DMPA, A, how long should she be concerned about continued risk for HIV? B, should we recommend that she continues condom use for 3 to 6 months? And C, would switching to a different contraceptive impact the residual effect of DMPA?
Okay, thank you. So we actually, when we issued our guidance, we have actually not examined in great detail that particular question. But what we can say is that for any woman or girl, client who's at high risk of HIV, that they should consider protective measures to protect themselves against HIV, because the only contraceptive method that actually is a dual protective method currently is our condoms. So if a girl is using another method other than condoms, she needs to, and is at high risk of HIV, the use of condoms or other protective measures are advised. As far as the residual effects, we do not address that in our consultation, and I'm not as aware of that issue. So we do not issue any other recommendations on additional measures that should be taken if a woman discontinues DMPA. The only recommendations we do offer about moving to a different method would be that to make sure that it adheres to that the recommendations and the selected practice recommendations are adhered to. So the timing of initiating the method so that it is as effective as possible.
Okay, and thank you, Marilyn, for that response. I can see Martha's hand is raised, and she's also unmuted. So, Martha, can you go ahead with your question or intervention?
Thank you very much, James. Thank you to the panelists for the useful and very informative, information that you've given. Considering the next steps, it seems we were in April 2017 participating. Then as community, for me, my interest is as a community member. And then I think there's been maybe inconsistency in terms of engaging community with the steps that are taken, because with the country steps that are going on, I'm not sure how much communities of women living with HIV are involved in terms of actually the communication strategy, and also what the decisions have been made by each country, whether the women living with HIV were part of that. Because definitely on my side, I didn't know that intervention happened. Maybe I just missed an email or something, but it got me wondering whether in general this is happening, and whether with the communication strategies being planned, communities of women living with HIV are actually involved. Thank you.
Yeah, thank you, Martha, for that question. And maybe I'll ask Nancy to respond if she's aware of the involvement of communities of women living with HIV in terms of this development, these activities in the countries, and also maybe any of the country folks that we have on the call. If you have some feedback, then you can raise up your hand, and after Nancy's comments, then we can call on you. So first, I think we'll have Nancy.
Thank you, James. So when we get the reports from the countries, they just give us a general report that they debriefed the stakeholders. We then expect that in the debriefing of the stakeholders, they would have all the people who have a stake, including women living with HIV, CSOs, and the other people who have a stake. So we don't have the particulars by country on the stakeholder profiles, but all the countries that came from the meeting did say that they debriefed the technical working group and other family planning stakeholders on the statement, and then they have disseminated it, especially Uganda specifically printed and actually distributed copies of the statement across the country. So we would have to probe on the stakeholder profile of the people who attended the dissemination meeting.
Okay, thank you, Nancy. Theopista, did I see your hand raised? Theopista John, from maybe you had some intervention from Tanzania?
Theopista, your microphone is open. Please go ahead if you have an intervention.
I can see she's still muted. She needs to be unmuted.
While we work on the muting issue, James, Theopista's question was, regarding the question which was asked if countries are counseling on the potential risk of HIV, currently the ministry and partners are continuing with intensifying capacity building on counseling to ensure that providers are providing the correct information, as it is in the recommendation, while awaiting the final results of the ECHO study. In addition, a communication strategy is being developed. She wanted to point this out because she thought the link would be helpful. We'll try to unmute Theopista to see if there are any further comments from that side.
Okay, I think thanks to Theopista, at least for that insight that there are actually changes happening at the point of service delivery in Tanzania. And maybe we move over to Charlie. You had your hand raised. Charles Morrison.
Right.
Okay, go ahead.
Charles, your microphone is open. Please continue.
Oh, no, sorry, that was just a mistake. I don't have a question.
Okay, thank you. Yeah, thank you. I think we do not have any more hands that are raised, and we're almost at the end of our time. I think in summary, I would like to say that this was a very good follow-up, and particularly I congratulate colleagues in the countries for the hard work that they've done to follow up on this particular guidance, and we will be sharing the link to the paper that was written by colleagues here on the process of translation from research and through guidelines to practice. And I think this has been quite an eye-opener for all of us that have been involved in this process. Some of the challenges that we face in the process, and it's been a continuing learning exercise. We all look forward to the launch of the Global Handbook for providers. As was said, it will be on 15th, and it will be available on the website that were given, and we'll be providing links, and we hope soon we'll have some print copies. Finally, also to say that the webinar has been recorded, and it will be available. The link is there on that slide where you can find the webinar, where the webinar will be posted. So for colleagues who are not able to attend, the webinar will be available on that link from tomorrow. I give special thanks to Ados and Stephen, who have really provided excellent technical support for us for this webinar. And say all of you, please have a good day, good evening, depending on your time, and we look forward to further follow-up on these issues of DMPA and HIV acquisition risk. Okay, bye-bye.